A2.
There we go. All right. Da, 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 da. Here we go. All right, fall down the stairs. Everyone still see everything okay?
Yeah, we see you. No presentation.
Perfect. All right, Woody, we're good. All right, thanks guys, sorry. All right, back to lady fall downstairs, go boom, and has a collarbone fracture. Got pain meds, and as expected, shortly thereafter, I should say not expected, but not unexpected, she then dropped her O2 sats, got put on oxygen, got to UC just fine. I looked over the case, and I liked everything in the management except for one thing, EKG. For patients who have falls or found down, based on the medical literature, what we have found is that you've got about 50-50 chance of having them have both a medical and a traumatic injury associated with either being found down or having a fall downstairs. The East trauma guidelines for like particularly found down patients has found literally about half of them end up having a medical and a traumatic problem leading to the as that end up being their final diagnoses. In that data, what they found is that you don't necessarily know which caused which. It could have been a medical event that then led to a fall. So, say a person who had a sudden arrhythmia that then caused them to fall, smack their head, and now they have a subdural, or it could be a traumatic injury that then led to something medical. So, say someone who fell, broke their hip, and then they've been laying on the ground for 16 hours, and now they have developed muscle breakdown that has led to a condition called rhabdomyolysis. But with that, basically the East, which is a big trauma governing body, has recommended that patients who have had non-mechanical falls or patients who have been found down after having been down for an unknown period of time, particularly in elderly patients, have a very high index of suspicion for something medical going on with them. So the one tweak I would have for this patient, having had that fall, particularly with her not having much memory of the event and having gone down that many flight of stairs, age, etc., is I would probably recommend getting an EKG on someone like this, in addition to the other things that everyone did, to make sure we're not missing some, like, God forbid, a STEMI, or showing that, hey, look, she's now an AFib or something like that, that could lead to a reason that she has a fall. The other reason I say this is that we see this on the MD side all the time, is we end up anchoring on it's a traumatic injury. And then you find out substantially later of like, oh crap, this patient actually had something else going on. And this is something that, as from the pre-hospital side, you can help kind of counter that anchoring bias by starting that work up ahead of time and having a high index of suspicion for something else going on. Um, Everyone did a good job with the rest of the things in the case, including get like a glucose on patient, watching your O2 sats, everything else. Love it. That would be my one tweak for someone like this or a found down patient. Would be making sure we're taking off common things such as making sure we're not missing arrhythmias or something with the heart. And Chris, as always, if there's something else, please feel free to jump in.
Oh, yeah, the thought here too, sometimes these are paroxysmal rhythms, right? And so
Yeah.
sometimes the only opportunity we have to see them actually is in the time and space that you guys are with them.
True.
I've shown this group, probably not recently, but in recent memory, when it comes to stroke, sometimes the only time you'll see AFib is actually on that pre-hospital 12 week, and that really does change management. And similar things could happen here, right? So that
Yeah.
if you catch a bradycardic rhythm or something like that, or catch, kind of other kind of weird morphologies to the 12 lead, sometimes it really is like only in that setting.
Cool. I didn't realize that part of the stroke literature. That's good to know. Makes sense with it being right around that kind of peri-stroke period or peri-event period, for lack of a better word. Huh? Oh, sorry. Close. That can go away. We know. We're just gonna roll with this. And let me know if anything looks funky, Jason. So next one that I looked at in regards to cases for the month, this was an odd case that I brought up just because it can be someone that can end up being very critically sick. So this was one that 75s went to, oldish gentleman, like 51, who was complaining of chest pain, but then had sudden onset associated left-sided weakness with those symptoms. Um, Patient with that, when they got there, patient was still complaining of a lot of chest pain, did a 12 lead that looked like it was okay. Did also notice that the patient ended up having some weakness on their exam on that left side as well. Had a brief loss of consciousness associated with it. Team did all the appropriate stuff, got them access, took patient to UC, and they were treated basically like the stroke scale was redone, treating this patient like a potential stroke patient. And the patient had a variable exam at that point. So the reason I brought this case up is something that we talk about a lot is the chest pain plus player. And the first thing that went through my head when I read this, and when I looked at the note from the ED on this patient, this was one of their concerns as well, is something called a dissection. So in this, what you have is blood actually ends up tearing apart the layers of a blood vessel. Aortic dissections we usually describe as being chest pain plus type of disease processes because the main branches off of the aorta end up going to critical parts of the body and can lead to a lot of other funky symptoms associated with that dissection. So on this picture that I've got on the bottom, it has the main branches of the aorta. So you've got, first of all, the coronary. So some aortic dissections will look like a STEMI. They'll oftentimes describe this pain actually going to their back from the main aorta itself ripping and tearing. But if you see that plus a STEMI, it's often because the other artery that's involved is the patient's actual coronary arteries being dissected themselves. And this can potentially lead to blood collecting in the pericardial space, leading to pericardial tamponade and can kill people. Other things you can see with this, depending on where that dissection flap goes, is stroke mimics. These people can look like they're having a true stroke because it dissects up their carotids. One that my colleague transported about 18 months ago now, the dissection flap went through the carotid, all the way down, dissected into one of the legs, and dissected into one of the kidneys. So this guy ended up with an AKI and ended up with a complete, I want to say it was left-sided stroke symptoms due to that dissection flap. I think this was handled very appropriately, like making sure they're conveying the concern for potential stroke for this patient. And they, when they scanned him, did not actually see a dissection flap. They think it might have been more conversion disorder where patient was having odd reaction to a stressful fight with his wife was what they found later on through chatting with family members. But this is one of the things to bear in mind is a potential dissection. One thing that can be helpful is if you see these, if that dissection is causing stroke-like symptoms, you may end up seeing unequal pulses in patients. These are the types of patients, my chest pain plus players, that I will actually feel both their radials and like both of their feet pulses at the same time to make sure that they feel like they are symmetric. I have seen a couple dissection patients where that dissection flap ends up causing you to have unequal pulses or even potentially absent on one side due to that disruption going through that dissection flap. So if that's one tweak that I would add, that would be it. Otherwise, I think this was very well done. Anything on that one, Chris? Okay. Next one, there's a little bit of a discussion on, I had two cases of DOAs that I wanted to dig into a little bit this month. So this first one was dispatched as concern for non-breather patient.
Actually, can I make one comment on that dissection?
Please, yes.
If you have like classic symptoms of like dissection, it's like sudden onset, ripping kind of pain, it goes to the back, maybe you have unequal pupils. If you have some preponderance of that, maybe you're missing one, but like it's like this is like probably a dissection. Even if you have like I'd probably have you hold off on the aspirin in that situation.
Great point. Yes.
Only because obviously like when you start getting into like the different layers of aorta and stuff, bleeding is the concern. And so you could very easily justify like, hey, we acknowledge that this is chest pain. Could be 100 different things, but the way they describe it makes me worried about dissection. So we actually held on the aspirin. The urgency to get the aspirin technically is in the first 24 hours. It's nice when you are able to do it as soon as we can, kind of thing. However, if you're worried about dissection, for any number of reasons. History is probably the most important.
They're saying they can't hear you talk.
Oh, no.
Here.
So. You wanna come over here and?
So what I was just saying is if there's like classic historical elements, the way they describe the discomfort, tearing chest pain, radiating to the back, they're hypertensive, at least to start, maybe even have unequal people, some combination and probably a preponderance of any of those historical or objective findings. And such that section is like pretty high on your list, I think it'd be pretty reasonable to hold on the aspirin in that situation. Because obviously with dissection, bleeding is kind of the problem, is it kind of dissects into those layers of the aorta. And so you are well justified, I would say, in holding on acknowledging that it's a chest pain. It could be an anginal equivalent or something along those lines. But if your suspicion's high enough, really the benefit of getting aspirin in a ACS patient is really in the first 24 hours anyway. And so if you have a high enough suspicion, acknowledging a differential, and you wanted to hold off, as long as that's properly communicated for the reasons that we just talked about, I think you're well justified. You may end up kind of saving some bleeding issues down the road if that history is. I mean, go ahead and give it if you have chest pain worries, but if it really is like that ripping, tearing chest pain, hypertensive, I think you're actually probably well justified in holding off on the aspirin in that situation.
That's a really good point. Thank you for going over that. All right. Next two that I've got that came up and I wanted to compare and contrast a little bit was DOA. So this first one, patient with a history of liver failure that she did not convey the severity of to family members. Family members found her and noticed that there were bugs flying out of her mouth. Fun times. And they called 911, but didn't want to start compressions due to psychological consequences of starting compressions for family members, but hadn't seen mom well since the day prior. Our crew found her unresponsive, apneic, and found signs consistent with death. They noticed on this patient that hi chief, that she had dried substances around the mouth, but also noticed rigor on the patient, lividity, other things consistent with death, as well as the bugs flying around the patient. So with this one, the patient was discussed as being dead at the scene and termination done appropriately. The second case I wanted to bring up as a contrast on the patient. This was another patient who was called with concern for DOA. And on this one, family members hadn't talked to the patient since the day prior. And I think this case ended up taking place like just shy of 24 hours after the last known contact with family members. So when they got there, found the patient was lying in his living room, had some modeling. And I think the description on this one was that there was some tightness around the mouth as well on this patient. And they ended up just declaring the patient dead on the scene. This comes up as I have to review all of the DOA cases for Unit 1 and CFD, and this comes up a lot when I look at them. Is kind of the concept of, is this patient dead right there, or is this patient in the Princess Bride setting mostly dead but not quite dead yet? And that's kind of how I've gotten to the point of thinking about our protocols for patients. The patient that's dead right there is your patient who we're going to do no resuscitation efforts on, and we have a separate protocol process that we go for those patients. These are patients who you look at them and you're like, yep, they are very clearly dead. The patients we're doing cardiac arrest management on, I put them in the mostly dead category. So they are dead, but they are still in the potentially salvageable phase. That potentially salvageable phase may be, that time frame may be a little bit nebulous, but those are the ones you're going to work. For Southwest Ohio, they talk about the dead right there patient, or the one where you have to do no resuscitative efforts, as one who has a DNR, has something in their body that makes resuscitation impossible. So their head's been cut off, their body is cut in half, burn beyond recognition, or the patient has been clearly showing signs of long death and early decomp. And it's specifically things such as rigor mortis, lividity, and decomposition. And then you can also throw MCI into the mix. This criteria is very specific, and that is on purpose to protect the pre-hospital providers, making it very clear that there was nothing that you could do for this patient. It is also supported by NAEMSP in their description of patients that are truly dead, no resuscitation efforts are needed. In Southwest Ohio's protocol, currently, we could comment on that. You don't have to do anything with these patients if you see these very clear signs of incompatibility with life. Like, don't have to do a 3-lead, don't necessarily have to listen for lung sounds, because these are very clear criteria that go with someone being dead. In the absence of these, finding these findings on your patient, the current protocols recommend going through a ACLS process for patients, or ATLS process for patients, because they are in that mostly dead category going into the dead phase. The second case, the part that bothers me a little bit on it, and I've seen this all the time, is in those cases, they're talking about rigor of the jaw. And I will talk about why next. I tried to spare everyone the gross pictures. You're welcome. I had took a nice dive down PubMed and the internet. There are 3 things that pathologists, coroners, everyone looks at in the early stages of death that help confirm a dead patient, and they progress over the first 24 hours after true cellular death. Number 1 is the patients get cold. They call it algor mortis, get rigid, rigor mortis, and then the last one is this staining due to the pooling of blood and other fluids inside of the body, livor mortis, which we call lividity. Rigor has a very specific process that it goes through. Initially, when patients die, they become flaccid, so completely drop over flaccid. Then over the first 1 to 2 hours after death, you start having this stiffening process as the body uses up its last little bits of ATP, but it's not able to relax until the muscle cells start to break down and fall apart. That's what causes rigor for people. And weirdly, it is in a very progressive, proscriptive pattern that the body goes through, and pathologists can help use this to determine when the patient actually died. The thing that bothers me when I looked into this is the first thing that goes into rigor is the mouth, the eyes, the mouth, the neck. Then it goes from the head down to the rest of the body. At about 12 hours after death, the whole body is completely rigid. And then over the next 12 to 24 hours, when you're going to start seeing true decomp set in, that's when the rigor starts to break down for bodies. The problem, though, is that there are mimics for rigor mortis, some of which could potentially, you could see in a patient who is not completely dead yet, who is in that mostly dead category, which is why I wouldn't necessarily anchor on the jaw rigor for a patient. You can see that in someone who is frozen, as well as someone who has been severely who has been very hot, someone who's been burned, someone who has had a muscle spasm, say from an electrical injury. You can see this as well as in patients who have a heat reaction to different types of medications, like malignant hyperthermia is another one. Those patients can potentially still be salvaged, but they may look like they have rigor because you can't open their jaw. So when you're looking at rigor, the recommendation is to look at rigor in the setting of what's going on in the environment around it. Are they also, and trying to look for some other indication that the patient is dead. So when you're looking at, when you're documenting these, it's really helpful to say, I have rigor and the patient is cold, though it is hot outside, and I have lividity, and I have early signs of decomp, and I have the sunken eyes or other things that very clearly fit with someone truly being dead. I had a couple cases, not here, but I have reviewed in the last year where they said the patient is warm and it was warm outside and the patient was not able to open the jaw and they called that person dead. And in the retrospectoscope, when we look at that from a medical side, I can't 100% say that that patient was truly meeting that criteria of dead right there or a truly dead patient. There are a couple things that can look like rigor that cause patients to be stiff, and those are incompatible with life. Those is this cadaveric spasm and stiffening that actually happens from the gas breakdown in the bodies. But with those, you're going to see other signs of death, like that lividity. The patient's going to be cold relative to the ambient temperatures in the room. Those type of things. So my recommendation on the pre-hospital side to kind of protect all of us and make sure we're doing best care is try to document and look for 2 signs of death, lividity and rigor, cold and rigor relative to the ambient temperatures in the room. And if you find rigor that's in like arms or legs, or it's like in the arms but hasn't met the legs yet, that's going to be more consistent with true rigor based on what I found from the pathology literature. Anything for that one on those, Chris? Not a fun topic, but one that did want to at least go over. All right. And we're going till 2 or 2:15, Woody?
To
2, okay. We probably won't get through all of the cases that I had today, but I've got a couple that I did want to look at. This one was one that was actually referred into us, and did think it was worth discussion. It was a patient who passed out at a gym. So younger gentleman who was working out, apologies, I meant to cut out the identifying information on the patient, but this was one who was at the gym, then described a headache, and then ended up having a passing out episode while they were at the gym. And then EMS was called to take the patient ultimately to Mercy Fairfield. This patient, the documentation that was done by the crew, I think was done very well, where they talk about the patient initially was relatively coherent, able to engage with providers, and they did document a lot of really good stuff, including a good pupillary exam where pupils were equal and reactive. But they note something about, which is really a dysconjugate gaze, or one eye is kind of going off in the direction opposite of the other, but no other clear deficits in regards to the neuro exam. While they're getting the patient over to Mercy Fairfield, though, do start noticing that the patient is becoming a little bit more combative, a little bit less responsive, less normal than prior. The management they did, I think, was appropriate. They notified Mercy Fairfield ahead of time, got IV access on the patient, did a 12 lead, did sugars on him, got him Zofran to try to help with the intractable vomiting that he had after his passing out episode, and got him to Mercy Fairfield appropriately. This patient got referred back into us because he ended up having a really nasty head bleed. When Richards and I looked at it, I'll have to double check for next month specifically the true findings that he had. I'll see if I can pull this CT scan to show to everyone. But this patient ended up having either a brain aneurysm or a arteriovenous malformation inside of the brain. So that's where you have abnormal blood vessel formation that leads to vessels that are more likely to burst in settings where you've had sudden raises in intracranial pressure. Aneurysms and AVMs, I kind of lump together in my own mind for patients. In those, you have patients where any type of sudden raise in that pressure in the brain can set them up for having this unstable blood vessel burst and then leading them to have a very severe brain bleed. Subarachnoid hemorrhage being one of the big ones. AVMs, depending on where they're at, you can have some bleeding inside of the parenchyma itself or an intraparenchymal hemorrhage. When we looked at his, it was in a very odd location. I think his was like occipital when we looked at it before, which even Richards looks at way more CT scans of the head than I do. And he even thought it was a little bit odd. Some things that can clue you into this being more of a severe brain bleed would be things or potential severe presentation, potential head bleed. Hypertension is going to be one of the big ones. Any patient that comes into me complaining of a headache, they've got hypertension where they're like 180s or above and they're puking their guts out with any neuro finding should raise some suspicion for a brain bleed for patients. It's usually going to be more subarach or potentially intraparenchymal. This patient, when I looked at the recorded vital signs for him, he interestingly was not hypertensive. We talk a lot about unequal pupil signs being a harbinger of problems in the brain, which it is. It's a harbinger of herniation specifically. And this patient, based on where the brain bleed was at, I don't know that he would be set up necessarily for herniation on that initial presentation. One thing that can be helpful, though, to convey to the physician providers is that dysconjugate gaze, where you've got one eye going in the direction opposite of the other one.
just inviting the funds
Oh, fair enough. So that was probably, if I was going to tweak one thing on the report that I listened to and the documentation for the patient assessment, I would probably convey to the providers that you're seeing this dysconjugate gaze because it's really the only other like clear abnormal neuro finding that I could see based on their report. Otherwise, I thought the intervention was appropriate, and I honestly looked at it over myself, and I don't know that I would have given hypertonic to this patient based on the description that I found in the documentation. But having seen more of these patients, I would have some concern that this was a potential setup for brain bleed. Uh-oh. Chris, I was curious what your thoughts were on this case too.
Yeah, I mean, it's tough, you know, the biggest part is just, you know, level of suspicion, because especially with like young people, like, it's not uncommon obviously for it to be something else, but when it is, you know, an MI or a stroke or something like that, they having a high index of suspicion is key. And sometimes those things like you're talking about, like just something weird on the exam might be the thing that kind of tips you off. I agree. I don't think you do anything treatment different. You know, hopefully they ended up going quickly to CT scan, because I know things moved pretty quickly once they got the diagnosis.
Mhm.
But I also get the sense that it was pretty sick in the back of the rig too, so I think things were moving pretty quickly.
Mhm.
But yeah, anything along the way, like clearly there was like there's something going on here. Let's sort out kind of what it is, and all those elements when they kind of don't line up or kind of give you the sense of like something wrong, then you know, having that as a pre-arrival is good and important.
And you found the head CT for them.
Yeah. Yeah, I like the I roll into the all over the place, that roaming nystagmus. That can just be a like when you see that in the context like intracranial stuff, you're like, oh,
Mhm.
this is something going on.
Yeah. There was a similar case from later in the month that I unfortunately didn't get a chance to look at her head CT, but this was more of the classic patient that I would expect to see a brain bleed in. Older patient, barfing her guts out, very hypertensive when I looked at the form. Like her systolics were 180, 190, 200, and having decreased mental status over the course of her presentation with the crew. Those are ones that where you tend to see, those are more of what I tend to see with head bleeds, at least from my experience so far. And both of them, looking them over, I think that the management process that I saw was appropriate. Like these would not have met necessarily criteria for hypertonic, but it is worth it to have a high index of suspicion for something intracranially going on with these patients, and then trying to get them to like CT scan trauma based, something like that relatively quickly. The other one that I had in regards to head trauma that came up this month is isolated GSW to the head. This comes up all the time for, I think, everyone, and was actually one of the topics that we discussed a lot when I was at NAEMSP, like what is the best way to manage these patients? This was a 24-year-old who had a single GSW to the head, and on presentation had this pooling and clotting around the base of the head, as well as was noted to be apneic, pulseless, pale, and warm. A 4 lead was done on the patient that showed that she was in asystole, and it was an unwitnessed traumatic injury to the patient. And ultimately, she was diagnosed, or she was found to be deceased. These patients, I would caution anyone with isolated GSW to the head based on current Southwest Ohio protocol, as well as some of the clinical experience that goes with them, for kind of putting these patients in the dead right there category. And there's a couple reasons for that. Isolated GSWs, it depends on what is involved, and we can't determine that until we put a patient in a CT scan, how severe their brain hemorrhage is. I have had a colleague who will tell you that she had a patient who, and I think most physicians will have at least a case where there is an isolated GSW to the head, and the patient ended up having some return of life. She had one where it was a patient who was shot by her partner, was actually a traumatic arrest, and they got her back, and she walked out of the hospital like 6 weeks later. Relatively normal person. And it depends, I apologize, I don't have great CT scans with goes with this. It depends on what structures actually end up being involved in that GSW, particularly if that GSW crosses midline or takes out the venous structure of the brain, the big venous sinuses. Those are very challenging for people to repair. But some of that can be very challenging to discern on patients until you get them in a CT scanner. if you have any chance of it being only one hemisphere of the brain, a lot of times those patients can end up being salvageable. And again, it depends on what happened with the ballistic once it hit the cranium itself. If it then blossomed into something that caused just irreparable damage, if it ended up being a lower velocity weapon that ends up having not as deep a penetration, there's a ton of variables that I don't think is fair to put on us in the pre-hospital setting to sort out. And I don't even like to make any of that determination without discussion with a neurosurgical colleague because of the nuances that are involved in it. In our current discussion for patients who have an isolated GSW to the head in our current Southwest Ohio protocol, we still treat these patients like a traumatic arrest. And it is clearly lined out in Southwest Ohio protocol to do that, unless you have some other clear determiner of death, i.e. rigor, lividity, cold relative to ambient temperatures. And it's because of those potential salvageable cases for patients. So on this one, the other thing that did come up was this discussion of like pooling of blood and coagulating of blood around the patient's body. I have seen that happen to patients in front of me in the shroom. And they are patients that are still actively being taken care of. So I wouldn't rely on that as an indicator of death. It may tell you the patient has been down longer, but I wouldn't count on that necessarily as an indicator that the patient has been down for a prolonged period of time. It's not a very reliable source and is relative to, was the patient on blood thinners? What was the temperatures in the room? Things like that. How fast did the blood come out? How long has it been sitting there? And those are things that are not really fair for us to interpret. Pathologists or forensic pathologists can look into that. For our current Southwest Ohio protocol, we still treat it like traumatic arrest, where you're still going to do at least good airway management, try to get access on them. And our protocol still says to do bilateral needle decompression on patients. And that's primarily because everyone has run into some story where it was looked like an isolated GSW, ended up actually not being an isolated GSW. And it's a simple thing for us to do, doing quick bilateral needle decompressions to make sure we're not missing a pneumothorax. That's what I had on that one. Anything else for you to add with that, Richards?
No, I definitely agree. I'm also trying to kind of find the original TOR rules. And then see exactly what the outcome of interest was that they compared.
Sure.
Because that's another kind of important conversation too. Is that,
Mhm.
you know, is it truly just like any survival, or is it attack neurosurvival, or these sort of things too?
Yeah, and some of the literature I know I've looked at this year alone for isolated GSW, like it is abysmally low for isolated GSW, the head that has gone in true traumatic arrest. I think some of the literature I looked at any survival, and some delineated out like intact neurosurvival, and it was still low, like in single digits for some of it. I don't remember exactly what it but we can go over that next month too if people are curious about it. I can dig into that a little bit more easily. And then last one I did want to go over for sake of time was this was the one. So this was an arrest that was run this month where they ended up running into access issues. And this is one of the things that I've had to look at myself over this year for access in a cardiac arrest. So I got called to, is this the one? Is it this one? I apologize, I'm trying to remember which one specifically. One of these two cardiac arrests, all of the arrest management I thought was very appropriate, and I liked the way that was documented. It was either this one at Chesterwood, or there was one where it was a truck driver that was pulled out of a truck, where they went to do a tibial IO, and they ran into a metal plate from a prior surgery that had been done on the patient. And thus we had to go to alternative points for access on a patient. So in traumatic arrest patients, I think most of us go to tibial IO because it's a very easy landmark for us to hit, except when you run into a big metal plate in the way. One thing I would like to bring up, and I'm kind of hoping that this will play, is one of the things that I found when you're looking at IO flow rates, The tibial IO we found, though it does get the job done in an arrest patient, it can be incredibly slow to get meds to the patient's central nervous system. So much so that there's been a huge discussion about swapping to a humeral IO. With a well-placed humeral IO, they found it to have comparable rates of medication delivery right to the heart of having put in a large central line on the patient. And then if I can get this to play on here, this was a video that was actually put out by Arrow. And on that, they show on fluoroscopy that the IO medications end up getting to the heart in like 10 seconds or less when you put it through a humeral IO site. So there's actually been a huge push to try to go to an arrest the humeral IO because you're more likely to A, get the medications actually to the patient faster, and B, get it to the central circulation where you're going to have potentially the most bang for your buck benefit with it. So that would be my one point potential feedback and suggestion, be trying to look at doing humeral IOs for some of our arrest patients, especially in ones where really any of them, but we found that ends up being more beneficial for getting meds done faster. Let me see if I can pull this up here, and then for sake of time, I think we'll have to cut it off. Can you guys see the screen?
Yes.
So perfect. So this is actually fluoro. And on here, so they're injecting a radio visible dye. And on this, here's your IO in the humerus. And then they start pushing meds. And within very short period of time, it is hitting the superior vena cava and going into the heart.
We cannot see the video if the video is supposed to be playing.
I can email it out.
We'll email it to you guys so you can see it.
Or
There is some talk that or discussion about in adults potentially looking at doing the proximal or the distal femur as another potential site for IOs. It is not necessarily a blessed site in adults though, through like Arrow or some of the other regulatory agencies, though in kids it is an accepted site for people to use. But I think for due to make sure we stay on time, I will cut it off there. And again, apologies for all of the technical difficulties this month. And we will see you guys again next time.